Chair, we've had apologies from Tony Zaman, from Vanessa Odlin, and Claire Eads is kindly here as her substitute, and from Professor Ian Goodman.
Thank you, Mr. Chairman. Could I just, on page 2 of the minutes, please, 1 to paragraph 3, I just want, for clarity, it's 1, 2, 3, 4, 5 lines down. Councillor O'Brien noted her disappointment that there had been little progress with regard to childhood obesity and that partners couldn't do more. Not sure how strongly I want that felt. I think at the moment they hadn't done any more, and obviously I'd love to see more. But obviously don't need that bit put in, but yeah, hadn't done more. Thank you.
Chairman. Are you happy for me to sit and write this? Okay, well, thank you very much for the invitation to speak at this meeting. Brunel Medical School is your local medical school, and we say a medical school for a changing world. Starting brand new, we have the opportunity to think about the future of medical education, to think about the sort of doctors that we want to produce, and actually thinking about the world and the changes that are taking place, some of them devastating, climate change, pandemics, conflict, which of course are challenges for the worldwide in terms of health and populations, and thinking of course about the changing burden of disease, which everybody here will be familiar with. And then thinking of that impact globally, but also the impact locally: poverty, homelessness, healthcare inequalities, and the NHS workforce capacity, the morale in the profession. And of course that's a national phenomenon, but that affects the local NHS workforce also. And I was aware, I said that as a draft outline of the strategy here, but I read the one that was 22-25, thought it was really interesting, and such a sort of joined up local response and vision, which which really struck me. So thinking about our medical school, which was sort of being set up, I mean it was being envisioned from about 2016, but set up certainly under my leadership from 2020, thinking about the future of healthcare, team-based care, person-centred care, the use of technology, and then of course health and well-being, tackling health inequalities, what can a medical school do, and thinking in terms of patient empowerment and transformation of healthcare through local partnerships, which of course is already happening in the borough, but how can a new medical school make a difference? And I think it will make a difference in 3 ways: through education, and that's first and foremost, we're training more doctors, through research and innovation, and then through local engagement. And of course, Brunel is a really interesting context to be setting up a new medical school for those who are perhaps less familiar. A research-intensive, technological-focused university with a very diverse student population, links with excellent healthcare partners, represented here today, in fact. And we're embedded, of course, within a college that has other professional programs, notably nursing, OT, physio, physician associate, social work, and a really strong track record of widening access to professional programs. So a really exciting place for a new medical school, and I think our ambitions as a medical school are really aligned with the university's sort of civic mission, committed to transforming lives and places in West London. So some key information about the medical school. We have an MBBS degree program. It's a 5-year undergraduate program. Our first cohort are currently in their 2nd year of study of the 5-year program, and currently all our students are international and self-funding. Of course, that's set to change because we found out last October that we will have UK students from this coming September. In fact, we're interviewing our first UK students next week, so that's very, very exciting. We also have a Physician Associate MSc program. This was running before the medical school was set up, but it's been officially absorbed into the medical school. That's a 2-year graduate program, and those students are all but bar one, I think, from the UK. So we've already got quite an interesting community of students, and that is how we our community at the moment. We have just over 100 students in each of our first 2 years of the 5-year MBBS program. They come from over 50 countries, so incredibly diverse, probably the most diverse in terms of cultures and countries of any medical school in the UK. And then we have our physician associate students, quite a small program, but running successfully. And then in terms of future intakes to the MBBS program, we're expecting 150 this September, of which 50 will be UK students, and we hope to have 160. We hope to have an additional 10 UK students for the following year. And of course, we have ambitions and plans for much more substantial expansion in the future, and we expect the majority of our students to be UK local students in future. We need government subsidised places for that to happen. And so the sort of doctors that we want to produce, we want to have doctors who come from diverse backgrounds. I mean, it's interesting, even with our international students, I had a couple of our students from India talking to me about how they were interpreting in the GP surgery here. So that's it is, of course, somewhat this area a bit of a microcosm for the global distribution of students. We want them to be prepared for these changes taking place in healthcare and society, and we want them to care for and empower their patients and have the values that will enable them to do that: kindness, professionalism, a teamwork ethos. So we're really instilling that in the way we teach them. I think lifelong learning and curiosity is really important. Medicine's changing so rapidly, and they will need to be adaptable and resilient. So what makes us stand out? I think there are a number of distinctive features about the innovations that we have produced in the programme. Team-based learning is one of them. We have no face-to-face lectures. We've replaced all of those with team-based learning, which means our students study their lecture material before they come to class on their own, and then in a large classroom like the one you can see there, they're in their teams of 6, but within one classroom, where they go through a series of assessments and quizzes, initially individually, then in their teams, and then they work on real-world problems related to the practice of medicine. So it takes links back from the science of medicine to clinical practice of medicine, all within the classroom setting. We also have a strong focus on communication skills. The team-based learning in itself is a great way of them to develop those skills, but we also use actors as so-called simulated patients in scenarios in separate teaching sessions. And I think really importantly, our students from term 1 of year 1 have contact with patients in the local community, and they benefit so much in terms of understanding healthcare from the patient's perspective. They're not at that point able to make sophisticated diagnoses, but they can really learn to empathise with patients. And in fact, primary care, of course, is a shortage specialty in the UK, and so we have a strong focus on that in our programme, but that also is a connection with the local community. And we're also mindful of the need to nurture student wellbeing, so we have our own student support team as well as the university team. And we've developed a house system. These are virtual houses, but it enables, if you think of students coming, 100 students from all over the world, this is a way of bringing them together, developing little mini communities with inspiring figures from medicine and science. And we have a clinician from a different healthcare background who's a senior house tutor, and then a number of different house tutors who are a mixture of scientists and clinicians. And this is the sort of house crest that the students have designed. Being a first cohort, they come up with all this creative inputs, which is lovely. So in terms of our success so far, I think the students appear to be thriving. This is very much out of the academic arena, and also within the academic arena. This was our first cohort who did very well academically. We had a lot of very positive feedback about the performance. We were also developing an identity as a London medical school, which again I think the students have been at the forefront of that, which is fantastic. They were invited to the London Anatomy Cup, which has been at St George's for years, and so that was and then I think other UK medical schools are coming to learn from us, particularly around team-based learning. So 2 very traditional medical schools, Queen Mary's and Manchester, are looking to convert from problem-based learning, which was very much in vogue and has been for many years, to team-based learning, just because of the evidence that it's more effective and actually from a resource perspective as well, and lots of very positive feedback. But there are also 2 very new medical schools as well, so that's also been fantastic, the collaboration and the interaction. I think our hospital partnerships have also been another great success. We have very much Hillingdon in the centre, but we have also, of course, Harefield Hospital that we're well connected with. And this is what's been driving this, of course, has been placements for our students, but I think it's also bringing other opportunities for collaboration. So in terms of connecting with the community more widely, we have, of course, primary care partnerships. These are all GP practices where our students are doing placements. They also not only interact with patients at the GP surgery. In year 1, they're doing home visits as well. And so that gives, of course, a real window into how people live in the community. And year 2, they're currently finishing our first cohort, these community engagement projects. These are some of the organisations that they have been interacting with. These have all been sourced by the GP practices that they're based with. And in fact, next week they're doing their presentations on their reflections of the engagement with these third sector organisations. And I think it's been a 2-way thing. I think that our students have really gained such a lot. We've also had some lovely feedback from our GP educators. This one was, obviously lovely to read from my perspective, but just talking about how they enjoyed their diversity and their eagerness and the excitement of students when they interact with patients. And I think it's lovely to read that feedback. I also wanted to mention the Brunel Hillingdon Engagement Network. I didn't realise it existed until a couple of months ago, but there's an engagement and strategy support unit apparently in the Office of the Vice-Chancellor, and this is an organisation that works with 25 Hillingdon charities and community groups. And so they, in terms of giving us feedback on our curriculum as we develop the later years of it, we're going to be involving these organisations. And that's one of our GPs who was letting the network know about the community projects I've just been talking about, because there was some overlap between the people who were visiting and the projects our students were doing. We've also been engaging with local students in widening access events. So this is a programme of events that we started actually before we knew we were going to have UK students. This was funded by HEE, an insight into health professions event. So the Brunel Widening Access team, we had, I think, over 30 young people from local schools and colleges. We worked across the college with the different professional programmes, and we gave them a simulation and a team-based learning experience that sort of mirrors the way they would learn in the medical school, and also taught them a bit about healthcare and medicine. And just to quickly to show, this is the immersive simulation room in the Mary Seacole building, and they followed a patient journey with a patient with a stroke, starting with the GP consultation, moving on to what is a simulated A&E experience, and then rehabilitation and follow-up. And they move from room to room with this experience. And then a team-based learning exercise, which this was very well received. And then in terms of other outreach activities, I just wanted, we sort of taking inspiration and working with, this is, I don't know if anybody here is familiar with HIOS, which is Healthy in Your Own Skin. It's a GP practice in Hounslow. Dr. Talak Mahmood, who you heard, yes, a very charismatic person who's absolutely passionate about widening access into NHS careers. And he's produced, I think, 1,000 videos, which are both around public education, but also to give information to young people thinking about careers in healthcare. And he's through these webinars reached 3,000 young people. He wants to make it 100,000 and work with us so that we can draw more people in and use our facilities for face-to-face events. This was an in-person event where he had 50 young people who came in and had some interactions with different members of the healthcare team, and we want to sort of have a version of that in Brunel with, of course, a larger number of young people. We've also been involved in a STEM outreach program called Girls in STEM, which is run within the university to inspire young women to consider STEM a STEM subject as a university career choice. So I didn't have the photos, but it was a really fun session with young people from local schools. So just some next steps, last few slides really. Of course, our key priorities, we want to successfully graduate our first cohort, which we expect to do in 2027. And that is the time when we expect to have full GMC accreditation, because it's when the first cohort graduates that they take the pressure off us a little bit, and we have until then we have a very intensive program of visits, feedback, etc., quite appropriately, of course. We're also going to prioritise recruitment of local medical students from widening access backgrounds, so we're going to have a programme of events. It's been a little bit ad hoc until now, but we're working on a strategy. And we want to, of course, expand our MBBS and our PA programmes. And I think, of course, we want to grow our reputation for educational innovation and excellence. I think some of the challenges ahead for us are maintaining our inclusive, supportive environment with a larger number of students and then a mixed cohort of UK and international students. I think it's a challenge, but it's also a great opportunity to create that culture and sustain it. I think the ability to be agile and responsive is quite hard in a university environment where things move quite slowly, and we want to move very fast. Placement capacity, of course, and then capital funding from medical school building, housing, etc. Student bursaries will be a big thing for us to think about. So finally, I think the future for us is expansion. We want to, from 100 where we are now to 250 is where we want to be, subject to government funding becoming available. We want to introduce a new 4-year MBBS programme that's in line with government expectations of shortening medical training. We can only do that once we've graduated our first cohort, so that will come afterwards. And a greater range of community placements, particularly social care, I think. Focus on interprofessional learning. And I think, there is an opportunity for the medical school in the future to be driving or working, at the forefront of the local public health research agenda. And really, we want to be very much integrated within the local community. and it is we see ourselves as being a medical school in the community, for the community. So, thank you.
Thank you so much, Naomi, for that really actually quite inspiring presentation. I'm going to open it to questions and comments from colleagues in the room. Anyone want to ask Naomi a question or make a comment?
Please.
Jane.
Yeah, inspiring, absolutely. It's really refreshing for me to hear about team-based learning. I think that was the thing that brought a smile to my face, that people are learning in that way, researching it themselves, sitting there around the table. I think that's what I'm really enthralled by, to see this. I think it's absolutely superb. In terms of social care, I suppose what I was thinking there is that our vision in this borough is to keep people out of hospitals, and by collaboration with our partners around the table and our voluntary sector, we hope to keep people out of hospitals. And I suppose what would benefit is if how can I say this? We all need to see that. So we need to see, as healthcare people, need to see what staying out of hospital looks like in this borough. So I'm just wondering how you think you can show your people there the benefit of great early intervention, GPs referring in the correct way to social care if it's not a medical intervention is not necessary, so that we're not all picking up each other's work too late or too early. Have you got any thoughts about that?
Thank you very much, Jane. And firstly, about the team-based learning, we'd be if anybody's interested in coming and observing a session, we're more than happy to facilitate that. In terms of our students experiencing the way patients are kept well out of hospital, I think these community projects they're currently doing is certainly a dip in toe in the water at that. It's a first exposure to seeing that. So they're doing their GP practices and then they're going out to. But I think what would be really good is if we could formalise that from a small project to actually a clinical placement where they could have a somewhat more immersive experience. And I think that's something that we are looking at in the later years. Because we've had very good feedback as well from the students, so they've clearly valued it. We know it is valuable for them, so I think you're absolutely right. It's something we need to make happen.
Eddie.
Thank you. Again, really applaud what's going on with the new medical school. I know practices that are heavily involved in Hillingdon, and obviously Professor Ian Goodman and others more involved than others. There's two areas I wanted to ask about. One is about the growth of the medical school in the next few years and how we could work together in order to build the capacity that your students are going to require, because certainly in primary care there are practices already that would like to take more students but are struggling with the capacity, and how things may be a bit more innovative and flexible as to how we accommodate so that we can have as many of the students as possible actually working in Hillingdon. And then I guess the obvious thing after that is, given the profile of the students, what we might be able to do to retain all that great investment and retain some of it within Hillingdon, so that some of the great students actually stay local and get involved longer term with the local community. So two parts really.
Thank you. And actually, just to your second part of your question first, maybe. Certainly, even amongst international students, we know from other schools, historically, we would expect around 70% are likely to stay. for some years afterwards, if not long term. We don't know, for sure, but that's certainly from UCLan and from other. So I think there is, with our international students, we really are preparing them for the NHS. And I know for a fact that a number of them have been quite inspired by general practice because they've told me so. That's, I think, having that early exposure to primary care and primary care role models is probably the best way of keeping them in primary care. And I think, again, the evidence suggests that graduates tend to either go home or stay where they graduate. That seems to be the pattern. So that kind of bodes well. In terms of capacity, yes, I agree. We've got big plans, and I just put placements as a challenge, but that was a little bit superficial. We are, one, of course, using technology is one way. We're looking at live streaming technology at the moment, which a group in Leeds in primary care have been using that, so that you have students in the practice and the GPs wearing sort of glasses, and you are live streaming the consultation so that those in a remote location are participating in it. So that's one approach. But I think, I don't know, I'd welcome also ideas about how I'm certainly aware of that challenge, because we don't want to scale back the primary care exposure, but we just need to find a way of making it work for more students.
Kelly.
Thanks, Naomi. Just a comment and a question. So my comment in relation to your presentation is fantastic that public health and community-based understanding of what drives health is really key to all of this, because certainly public health has for many, many years, up until probably about 10 years ago when we joined the local authority, has been driven by a very medicalised approach without really understanding that, well, there was an understanding that clinical provision accounted for sort of 20% of overall health, and actually the environment that people live in, the behaviours, obviously you know this, account for significantly more. So the fact that public health has been put back onto a medical school agenda when it has for many years almost lost its status, because postgraduate training, it's now no longer a core requirement. I suppose my two questions for you is that, one, what do you see when you get your first graduates out in 5 years' time? What difference do you see coming out of a medical school where you've taken a very different approach? What will that doctor look like that's different from that very traditional perspective? And the second is a kind of an offer, is public health really exists in local authorities. It's found its place here. So what drives health is housing, education, employment, green spaces, and the environment that people live in predominantly. And I sort of wonder, rather than just adult social care, it would be fantastic if your students were able to see and really understand how people live and how that affects their health and well-being, because really from a truly preventative and early intervention position as a doctor, understanding those wider determinants is absolutely key.
So that, and your second question was then how to make that?
Yeah, how can we make that happen? Because clearly the local authority and Brunel have a partnership, but even just to understand in terms of short-term placements within the local authority, what does it mean to be homeless? What does it mean to struggle to find a place to live? What does it mean for your children not to be ready, able and willing to learn, or prepared to learn by the time that they start school, and those inequalities that really drive lifelong impact and lifelong poorer health?
No, thank you. And I think, again, it would be interesting if once I've heard the reflections of our students who've done these projects next week, that will be quite interesting to see what impact it's had on them and the way and their understanding of health from that perspective. In terms of how I see our students being different when they graduate, well, I think we are aiming to create generalist doctors in the wider sense of the word. So we're looking, of course, primary care exposure and an understanding of public health, but even community-based care, and probably I suppose our students are having less of an exposure to big tertiary centres than many other, say, students at Imperial or UCL, for instance, and looking at community-based care even when they're in the hospital environment. So I think they'll have an awareness of what the community has to offer in terms of care, an understanding of the importance of health promotion and prevention, and that will, I expect, will drive some of their career choices, but also some of the way that they interact with their patients. Because even in if they choose to be a hospital specialist, understanding what's going on in the patient's life, how understanding healthcare from their perspective will, I think, affect the interaction that they have and make them a more caring, compassionate doctor. I'm not sure I've answered all your questions, but I think if we get that embedded into...
Sorry. Naomi, if we can get that instilled right from the outset as fundamental to health and well-being, and it's not just a clinically led and clinically driven profession, that would be huge change in terms of, for some of where we are now is really driven by that lack of understanding.
And perhaps you could come and talk to our students as well.
Yeah, happy to.
Yeah.
And on that happy note, I'm going to draw this part of the discussion. Naomi, can I thank you for coming for that? And I think you can see from how it's been warmly received. I think it's a real breath of fresh air. So we do note that. And can I just introduce one note of levity into the conversation? Just when you put the house crests up, I didn't read the names first. Oh my God, they've gone for Gryffindor and Ravenclaw. But thank you, and thank you for coming. Okay, colleagues, so what we're going to do is to move on. It's just to note that agenda item 6, which was on the agenda, that J9 co-chairs have agreed to defer that until our next meeting. So with that, we're going to move on to item number 7, which is the Integrated Health and Care Performance Report. So Gary, over to you to introduce this report.
Thank you, Chair. Just a few points to highlight, and to start off, I think, with a piece of spectacularly good news, which is always good to start off a report with.
This is the Health and Wellbeing Board. You don't want any good news.
Oh, sorry, wrong meeting. Which is basically the result of the Ofsted inspection of children's services, where we got a finding of outstanding. I'm sure Julie may want to add something later. And as a sort of segue from that, we've recently been informed that adults are now actually going to be going through a similar process later in the year with the Care Quality Commission, and we're currently in the process of compiling the evidence to submit to CQC at the end of this week. Undoubtedly entail a lot of work with providers, but I think we certainly do have a good story to report to C-Sky. Moving on, I've mentioned within the report about the Q3 performance template that will be signed off under delegated arrangements. There are still some further queries to actually address on that, but I'm hoping to get that resolved shortly so that we can address and sign that off under agreed delegated arrangements. Within the report, I say that I'll provide a verbal update on where things are with the 24-25 Better Care Fund arrangements. The publication of the planning requirements has been postponed until after tomorrow's budget, So we are hoping that they will materialise before the end of March. And it is understood from discussions with the Better Care support team that we are likely to get approximately 6 weeks in which to prepare our submission. To highlight a couple of other successes, I think from the report, the population health management infrastructure posts that have been the subject of discussion at previous board meetings are now actually out to advert, and we hope to be in a position to undertake the interviews in April. And have a positive outcome to report to the next board meeting. Equally, another success is the actual opening of the second same-day urgent care hub, which I understand actually opened in October. Moving on to the issue around hospital discharge and length of stay. Bit of a mixed bag in that we have the lowest percentage of people not meeting the criteria to reside and not discharged within North West London, but the highest percentage of bed-based occupied by people not meeting the criteria to reside. The report actually sets out a number of actions that are actually being taken to address that. Moving on to another point, within the report, just wanted to highlight the issue of carers assessments and the request that board had from Cabinet and the Health and Social Care Select Committee, and this actually concerns the carers strategy delivery update that was considered by both the committee and Cabinet in November and December respectively, where we reported the high number of carers who were declining to have a carers assessment, and just to for the board's information that the importance of that is a route to access for statutory support from the local authority. Stated within the report the actions that we take about that, and what I propose to do is just keep the board updated with progress as we go forward. Thank you, Chair.
Thank you, Gary. And can I just, first of all, I think just extend the congratulations of the entire Health and Wellbeing Board to our colleagues in Children and Young People Service of an outstanding Ofsted report. And I think we're all collectively very proud of that achievement across Hillingdon. And what I would say, Sandra, obviously, is fingers crossed for the CQC review, and a lot to live up to. And I know you've reached out to health colleagues around the table on that, and obviously we hope that we will be able to reflect the strength of the partnership working that's been taking place across both children and adult services. So that's certainly would like that put on record, and so congratulations to colleagues and do that. I'm sure Julie will pick some of that up a little bit later. I've got a few observations, but again, any comments, observations, questions from colleagues around the room on the performance report? Kelly.
Thanks, Gary. Typically comprehensive report, so thank you very much for that. Just great that we have managed to maintain overall good performance. I think my starting point is that. Just in terms of adding some additional information, particularly around the integrated neighbourhood teams, so Eddie and Ian and I and Keith, we're going to align public health officers into those neighbourhood teams, because I think it's really important that public health works very hyper-local and actually kind of supports that sort of embedding public health, and as well as that population health management work that and the capacity that's going to be aligned with it as part of our long-term strategy. So just to add to that, you won't have known that because we've been doing that sort of in the interim period of time. Secondly, thanks for leading on the recruitment for the population health management work, Gary. I know it's been a sort of a long drawn out process with sort of male foodies supporting, so really appreciate that. The only other comment I would just say is just, and Councillor Palmer will know this, particularly around the cervical screening, and the cervical screening is kind of low, and you've put down as amber. It's also, cervical screening is one of the priorities of the Integrated Care Partnership, and that's, Councillor Palmer is a member of that partnership. She's the representative for Hillingdon. That is being driven through that agenda, and I think that as in addition to the work that we've been sort of promoting as part of the Health Protection Board, which many of us are party to, which is kind of a locally based driven activity to improve uptake in all areas of cancer screening, including the targeted lung checks. The ICP will also, sort of promotion of it, will also be a means by which we can learn from best practice about who's doing what elsewhere and what works. And I think together we can help drive up that, certainly that sort of lower uptake, particularly amongst young women. So I think, just to be aware, this has all kind of happened in the last few months, Gary, so you won't have known that unless you were at ICP. But thank you.
Thank you, Kelly. Susan, did you want to come in?
Thank you, Mr. Chairman. Thank you. I would just like to say that I'm quite pleased to see, first of all, Gary, a really actually very positive report, this one, especially on the children and young people side of it. So I'm really pleased to see that that some of the really hard work that's going on, multi-agency hard work that's going on has actually been able to be presented today at this board, and good work that's happening. It's good also to see that we've got 2 urgent primary care hubs. I mean, hopefully that will now start to alleviate some of the pressure whereby we have residents that some are struggling to get into to see people, and actually frankly shouldn't probably be going to A&E, so but need to go somewhere. So that's also very, very positive. And there was one other thing, and I can't find it now. I do apologise. No, I'll have to look for it. I did have it marked out. That's what happens when you read stuff online and then you come back to paper. So apologies for that. But thank you. Really positive report. Thank you, Mr. Chairman.
Thank you. Any other questions for? I've just got a couple before the Chairman's privilege. Patricia.
It's working. Just a quickie, on page 12 of the report, it talks about the number of patients receiving tests within 6 weeks of referral, and it talks about, for the period April to November, the average was 76%, which is an improvement in the previous 2 years, 86% in 22 and 73% in 2021. I presume the 86% is an error, just for clarification.
As that doesn't actually make sense,
No.
I would assume so. So I'll go back and check. Apologies, Chair.
Thank you.
You were just being polite there, Patricia, weren't you? Yes. Just a couple of questions and some comments just to take away. I am just thinking about some of our BCF discussions to come. I think we'll pick some of those up in private part of the board. But just in terms, Gary, again, just to take away, in terms of the issue on discharge, just to pick up what Patricia was going to pick up. In terms of the growth in the number of patients with long lengths of stay, we did analyse this, but it was post-productive of this meeting, and the reason why Hillingdon is an outlier on that is just because of an uptick on our elective lengths of stay that occurred during the junior doctor strikes in December, because we thought that just looked odd. How can you have low patients with criteria to reside and have and we looked at that in detail. So I think that's a statistical anomaly due to the junior doctor strike on elective admissions. Not that I know discharge metrics off the top of my head. Feels like that sometimes. And obviously the length of stay, or non-elective length of stay, came down from 5.9 to 5.4 in the last course. So in terms of some of those discharge metrics, they've been going in the right direction for some time. the bit I just wanted to pick up, and it's something for us to take away, and what I've agreed with Steve Curry in terms of end of life data is just to be a bit more clear on what good looks like in terms of some of the end of life, because otherwise it looks like having processes in their own right are good things, which they are, but they need to lead to a better outcome for people. So there's a couple of metrics that we've agreed in terms of the admission rate per 1,000 population to Hillingdon Hospital, where we do very well compared to other North West London boroughs. Where we don't do so well is the length of time that those people stay when they're in hospital, where we are an outlier in North West London. So what we're trying to do is to have some agreed targets where we maintain the low admission rate per 1,000 population. We begin to tackle the length of stay, which is around 10.7 days in Hillingdon, compared to a North West London average of 7 days. So we just need to work on both of those in terms of what we do, and I think having sight on those, I think, is quite important going forward. And I just wonder, I don't want me to put you on the spot, Richard, but if Ian Goodman was here, I'd put him on the spot. But just in terms of the cervical cancer screening issue, obviously we've got some actions in there. I guess the question is, because we are an outlier on this one, and it is a priority across North West London, it's just a question of whether we think those actions there will have the traction that we need. Sorry, it's a bit of a bouncer, but in some ways, having read it, it's I think that's quite important.
So just to pick up on that, I mean, I absolutely agree with you. That target is a real priority for Hillingdon, and I think Kelly will agree with me that it's a challenge across London, often for the younger age group as well. And I think in answer to your question, I think these actions are necessary but not sufficient. I think there will absolutely be more work that we need to be doing through the key community groups, and we talk a lot in a number of areas about the importance of getting some of the vaccination figures up. I think there are opportunities through all the connections we have with communities of emphasising the importance of keeping your families safe, but also keeping yourself safe, and making it as easy and as straightforward to access the screens or the tests and the support that we can. So I think the group looking at this will need to take that away and look for other ways of further expanding our reach. Sometimes that's identifying the right clinicians as members of the community groups, but it's also just about making the message, making the communication, making the access as simple as we can.
Thank you, Richard. And then my final question, which you think, why did you ask me this before the meeting, Keith? But just in terms of, Gary, in terms of the reablement still at home after 91 days data, is that because we don't collect it or we can't get it? Because it's normally quite a key metric when we're looking at reablement. Just if you've got that sort of...
We've had some issues actually getting the data together, but the data for the national metric, Chair, will actually be people admitted to hospital in Q3, and then and whether they're still at home during Q4. So that is the sample that nationally will be measured on and compared against. So, Chair, just to add as well that this metric is actually being discontinued from this year and will actually be expanded to all adults from next.
Thank you for that clarification, Gary. Okay. Sue, do you have a question?
Thank you, Mr. I remembered it, sorry, as I was going through the paperwork. I think I've already mentioned it in connection with preventative to the officers at the council, but I just wanted to put this out to our health colleagues as well, if you don't mind. Just looking at all of these workstream highlights and with the hubs that are going into Ruislip and Uxbridge, and it may be already in the bag with adolescent services, but I asked a little while ago about underage young girls, 13, 14, 15, 16, and contraception, morning after pill. At the moment, there's only one place in Hayes that actually, apart from chemists, that can do that, but where they have conversations and are able to speak to an adult when this happens more than once, I would really like to get some type of information, because it just doesn't happen in the south of the borough, and asking a 14-year-old girl in the north of the borough to make her way down to Hayes after having an issue is, for me, just a little bit concerning. So thank you. I see Kelly looks like she might have an answer, so I should have maybe have asked her outside of the room as well. Thank you.
Kelly.
So that, Councillor, that's not an NHS responsibility. It's a responsibility of the local authority. We're the commissioners of sexual health, including contraception services. So that is noted. We are in the process of transitioning to a new contract with London North West, who provides that service, and we're working with the wider council to look at where our services are operating from and the accessibility of those services. And actually what we're trying to do is get a very central location and start sort of building up the GPs and pharmacists who are providing either long-term contraception, because there's very few in number compared to other areas. If I look, yes, and emergency hormonal contraception is only available from a small number of pharmacists, when actually if you look around other North West London boroughs, there is greater access. But we need to have a conversation with the LPC in terms of how do we promote that, because something is a barrier to making that happen. But that's on the radar of our discussions as we move forward with that contract. And we're really aware of that gap, particularly in the north of the borough.
Thank you. Any other questions on that report? No? Okay. So just before we move on, what I would just like to do, because I know we're in the public part of this discussion, and it referenced at the start of the meeting. Certainly when we met with Councillor Dennis for the Health and Social Care Committee, we talked a lot about services to the Heathrow and villages. And what I just wanted to be able to report for the minutes is that after that meeting, a group of us, myself and Vanessa Odlin and colleagues from Central and North West London, met with the villagers to share with them a draft of an evaluation report that we did of the Wellbeing bus that we set up in order to try and bring more health services to the village. We had a very positive meeting with residents from the 5 villages. As a result of that meeting, we're in the process of making some amendments to the evaluation report, which we will make. And I think it's fair to say that we got to a place with residents where we identified a number of preferred options as a result of that. And just for the record to say, I'll be meeting with colleagues from Heathrow Airport tomorrow, and what's the link between the two? Well, Heathrow own a number of sites in the Heathrow villages, which we might be able to have some agreement around, just in terms of future provision of services. So whilst nothing is agreed, I just really wanted on record that we have taken that work forward. We have spoken to the villages, and we are carrying out some further work as a result of that, and I will report that back to this committee when it next meeting. So that's just for the record, Nikki, just for noting. And with that, can we just note Gary's report? Thank you for that report, Gary. And we've had quite a good discussion on that. If people are happy, then what I'm going to do is move us on to agenda item number 8 on local area SEND and AP strategy. Fabi, welcome to the meeting. Can I hand over to you?
There we go. Thank you, Chair. So this is to look at the new local area SEND and AP strategy, and I really must stress this is a local area strategy, so this isn't a council-owned one. This is very much about our partnership around SEND, and the new strategy includes the alternative provision elements, which is new, which is in line with the National SEND and AP Improvement Plan. So originally we had a draft strategy that was in the making and was looking at 3 key priorities. We looked at the consultation feedback amongst parents, families and schools, and recognised, in line with some more data analysis we did, that there were some broader ambitions that we were looking to include in this strategy than the original 3. So we expanded that out, and as you will see, our key ambitions are around the right support at the right time in the right place, so very much focusing around the importance of early intervention in closing the gap and meeting needs early. Ambition 2 is around fully inclusive education for all, so making sure that our settings, our communities are inclusive of all of our children and can meet a range of needs. Ambition 3 is around the type of provision, meeting the needs of Hillingdon's children and young people. Ambition 4, looking at children and young people live happy and fulfilled lives where they're included in their community. And Ambition 5 is around alternative provision and having a flexible offer and a range of interventions to meet children's needs. So you'll see the strategy is quite a big document with lots of data in it. We did extensive analysis to ensure that what we were targeting as part of that strategy was going to meet the needs of our children in Hillingdon, whilst also looking at the national changes following the Send an AP Improvement Plan and the Green Paper developments as well. We listened to the feedback from our schools and families, and also really put a lot of onus on feedback from our children and young people as well, and used that to inform what we were going to develop. I referenced in the paper there was some challenge from some of our schools. A lot of the challenge that we got back was really around the national priorities, which is something that's out of our hands, around increased inclusion in mainstream schools, looking at lowering the level of EHCPs, but not just to lower them, but that's through meeting the needs earlier, so that less children need to go on to a point of having EHCPs, and also around funding. So we know nationally there's a lot of challenges around SEM provision and funding, and there is a shortage in the system, I think, around how much funding there is to meet those needs. So there's a lot of work going on around SEND at the moment, and we're working very closely with Richard and Sue, Richard's counterpart, and the local area to make sure we have a real systematic approach to that. We're developing some training around systematic leadership, sorry, I can't get my words out, to make sure we have a real shared collective vision around what we're looking to do. We're creating a new funding model so that the funding that we provide for our children's needs is up to date. The current funding model we have is around 8 years old. We're also creating new needs matrices and provision matrices, so we have a real uniformed approach to supporting our children and developing clear admissions guidance for our special schools, and also working with our schools to ensure that they have the skills and the support to be as inclusive as they can be to meet a range of needs. So, like I said, it's a large document with lots of information in it, so it might be a good opportunity to stop and see if there's any questions, and take it from there.
Thank you, Abby. Questions, comments? Sorry, Kelly.
Thanks, Abby. I did have quite a few questions, and then I read the strategy, and it is very comprehensive, and it provides lots of lovely data. So just a few questions from me. Is that you mentioned that there was concern flagged by school governors and schools in themselves about the strategy. I wonder if you could explain that a little bit further. The second one was about the difference between boys and girls who have EHCPs. Put it down to autism, but there may be some other views. And I suppose any sort of issue about ethnicity being part of that. And I suppose the last one is that in one of the later slides, Harefield is a very noticeable sort of area that's coloured black, which shows it's got the highest level of children with, I think, quite a significant rate of EHCPs. And I just wondered, in terms of, it looks like an outlier in the borough, but I wondered if you can just explain that a bit more.
Yeah. Thank you, Kelly. So, as I said, going back to the first point around challenge with schools, it's a really hard environment to work around supporting special needs for everyone at the moment because of those funding challenges. Needs have significantly grown since the introduction of the Children and Families Act in 2014, and everyone's under a lot of pressure. So a lot of the challenges that came back were just concerns around more pressure being put on schools. It is challenging. You know, every child legally has the right to attend a mainstream school, even if they are children with very, very high complex needs, which can be challenging. Also, as needs have become more complex over time, the children that end up going to special school now are different from the children that would have gone 10 years ago. So it's putting more pressure on mainstream schools to deal with a higher level of complexity and need. So I think they were some of the challenges that were coming through, and really what we're trying to do is work with our schools collaboratively around those challenges, because there is no one right answer to some of these issues that are coming through. So it's really about having a collective ownership around what are our children's needs, what can we do, how can we look at things outside the box, and do things differently together, which is the only real way forward with that, I think. Looking at the point around gender is a really interesting one, and it's something that we see nationally as well, that there's generally a lot more boys that have special educational needs versus girls. And I think that is predominantly around ASD. There is a much bigger weighting with boys, and it's about 50% of our needs overall, if not more now, are ASD primary need. And it's a challenging one, because we don't know how much of it is that boys genuinely have a lot more needs than girls, or how much more it's to do with girls masking their needs. But certainly we see that trend through our data, that it's much higher need with boys than girls, certainly as far as issuing EHCPs. The point around ethnicity, I haven't got it in the strategy just because we have so much data in there, and we kind of got to a point where we thought we need to kind of try and keep it as concise as possible, but it is a really good question. We see it's around 32% of our children with EHCPs are white British, and the next biggest group is any other Asian background, and then we have a whole range of different ethnicities. So it is interesting looking at some of those trends, and also your point around Harefield. You know, we created those heat maps. There is a secondary heat map that we did, which is around the actual number of EHCPs, and Harefield is less densely populated, so the actual number in Harefield is quite low, but the number per 100,000 is very high. And I think that's because the demographics are not dissimilar to the south of the borough, so we see a sort of similar trend. So it's really interesting unpicking this data and understanding where the key areas of need are locality-wise, so we can really focus our support and our services around those areas, and to try and understand what we can do to get in there earlier and close the gap earlier. I think that's all your questions.
Derval, do you want to follow up?
Thank you, Abby. That was really informative. Just a question about the consideration that's been given to the strategy about support for families and primary carers, things like that. How does that sort of dovetail into this?
I think what we've done is try to think of our children and families as central to everything that we've put into this strategy. I think making sure that we're considering how families can access support early, can find the information easier, really trying to listen to those voices to work out where there might be challenges in the system already. So developing things like our local offer and making the information much more easier to source. And there's lots of plans to look at those services over time as well. I mean, the strategy are the key ambitions for now, but there's much broader work that we need to do, and I think the early intervention is the key part. But also for families, when it comes to those children that do need more support through an EHCP, making sure they have the access to the information that they need and they know how to go about doing that. So everything we've done in this is really putting the children's needs central, and the families as part of that. And we'll develop that more and more over time. I mean, these are the key umbrella ambitions, but there's lots of plans with the finer detail to really focus that support over time in there as well.
Claire.
Thank you, Abby. Claire Reeves from CNWL, covering children's services as well within CNWL in Hillingdon. So really welcome the new approach of the collaboration and the way in which we're approaching this. We're just wanting to come back with what we're doing around families waiting on waiting lists. We know that resources and funding is really tight. Thinking of different ways of working with yourselves and thinking about those children and families on that waiting list and how they can access other services, not necessarily just provided through health, but also how they can access them while they're waiting for those assessments of the strategic thought processes that go behind that. And so really welcome the new way in which we're working together.
Thank you, Claire.
Thank you. That's really helpful. And just to say, as part of the work that we did around the strategy, we did do some workshops with the NWL colleagues to really try and unpick some of those pathways for families, because the diagnosis shouldn't be the be-all and end-all. It's about how is the child presenting, what are their needs, and how can we try and meet those needs as soon as possible rather than waiting for something to say this child has X and Y diagnosis. And I think that's really important. I think we've made a really good start on moving that forward. I think there's a lot more we can do though. And just being really clear as a local area, how are we approaching this so that we can be really clear with families as to how they can access that support, and relying on the local area partnership to really come together with those solutions. So looking at our voluntary sector partners, seeing how they can support with those needs as well, turning to our schools and seeing how they can promote information and offer support and guidance as well. So I think there's a lot more that we can do on it, definitely, but I think it's positive that we're making a good start with that.
Thank you, Abby. Any other questions, comments before I move us on? So the recommendation of the paper, that we note the paper, and I'm taking from the feedback that is the will of the board, unless you tell me otherwise. Good, that is noted. Thank you. Okay, I think that moves us on to, well, I know that moves us on to the board planner and the future agenda items. So that is, members have got that in their pack. There is one other suggested addition to this, and I think Tina Benson from the Hillingdon Hospital has asked to come to a future meeting, and I would suggest side of agenda willing that we take that the next meeting, which is on the Hillingdon Hospital redevelopment and decant plan. So we could have that, Nikki, on the next agenda. Are there anything else in terms of the future strategy that people would want to add to what you've got in front of you? No. So can we take that with that one addition? Can we take that as agreed? Yep. Okay. So I think we've now reached the end of the public part of the meeting. Thank you to those members of the public watching on YouTube. And will everybody please remain silent until Democratic Services has confirmed the live broadcast has ended and the loop has been switched off. Thank you.